Respected Professor, Professor Nagaswamy sir, and Professor Dr. Vasanthi madam, and my dear students. Today we have our RAISA online WebEx paper and poster presentations by postgraduate students of RAISA postgraduate program in railway hospitals as well as non-railway institutions. Today we have four candidates as a part of our annual conference. This year we are conducting our 30th annual conference in Jaipur on 28th and 29th of September. And we have been conducting regular academic activities in during railway this Raisacon conferences as well as during the regular academic programs with the guidance and support of our beloved and respected professors, particularly Professor Nagaswamy sir and Professor Vasanthi madam, and many others to contribute. As a mark of immense respect and gratitude towards our teachers, first I want to thank them and submit my sincere respects and honor for my teachers and my professors. With this note, I would like to welcome our Professor Nagaswamy sir and Professor Vasanthi madam as judges for this today's competition for postgraduate paper and poster presentation. We have four candidates. One is Dr. Mohit from Department of Anesthesia, Jagjeevan Hospital, Mumbai. To start with, I invite Dr. Mohit to make his paper presentation. Over to Dr. Mohit.
Thank you, sir. Good afternoon, everyone. Today's my topic is ultrasound guided subcostal transverse abdominal plane block versus lateral quadratus abdominal plane block for post-operative pain after laparoscopic cholecystectomy. Introduction. The laparoscopic cholecystectomy is considered as a treatment of choice for symptomatic cholecystectomy. Pain after laparoscopic cholecystectomy is multifactorial. It's due to the peritoneal insufflation with CO2, training or irritation in the peritoneal cavity, sociocultural stud, and emotional factor. Pain after the laparoscopic cholecystectomy requires a multimodal analgesia technique. As a part of this, various truncal blocks are performed to eliminate the postoperative pain and reduce the need for opioid. In this study, we are comparing two blocks, the subcostal tab block and lateral quadratus lumbar block. These are my reviews. The aim of these studies is to compare the efficacy of subcostal tab block with lateral quadratus lumbar block for applied ultrasound under roundness as a method of postoperative analgesia in laparoscopic cholecystectomy surgery. Primary objective is to compare the pain at regular interval postoperative period, total dose of tramadol consumption in the first 12 hours in the both the group, number of the patient requiring the rescue analgesia in the postoperative period. Secondary, the comparison the intraoperative heart rate, systolic, diastolic, mean blood pressure in the two groups, and comparison of the incidence and side effect pain. Study area Jagjeevan Ram Railway Hospital and period 2 years and 6 months. Study design prospective randomized double-blind interventional study. Study population laparoscopic cholecystectomy procedure in the general. Surgery in the operation theatre of Jagjeevan Ram Railway Hospital. Sample size considering the mean, it's my sample size is 80, total 80, each group is 40. In inclusion criteria, patient of the either sex, ASA grade 1 and 2, patient is between 75 and patient weight from 35 to 90 kg. Patient scheduled for elective laparoscopic cholecystectomy. Exclusion criteria: mental disorder, laparotomy, impairing. Impaired bleeding diastasis, allergy to the drug, renal failure, infection at the site of block, and BMI more than 35. Hello. Methodology. This hospital-based prospective randomized double-blind interventional study was conducted in our institute for institutional ethical committee. All patients were randomized divided into double-blinded fashion using the computerized generated number into two groups with each 14 each group. The preoperative anesthetic assessment was performed, including the history, physical examination, routine investigation, all. and were explained using the NRS code before the surgery. All the patients are induced as per institutional protocol. After the induction of general anesthesia, patient group A or in group A, subcostal transverse abdominal spleen block was given were performed in the group in supine position. Probe was placed on upper abdominal wall obliquely along the subcostal edge close to the midline. After the identify the rectus abdominis muscle, transverse abdominis muscle was located below the rectus abdominis muscle by sitting the probe obliquely along the subcostal line toward the lateral. Using the linear ultrasound bone, 80 mm 22 gauge block needle between the rectus abdominis muscle and tam muscle. Same plane and in plane method. The prepared solution of 0.3 ml per kg, 0.25% bupivacaine, max 20 ml was injected bilaterally between these two muscles and observe the spread toward the lateral side of the rectus abdominis muscle. After the completion of tab block, the surgery was allowed. And the second group, that is a lateral quartus block, was performed in the patient in lateral decubitus position. The USG probe was placed on the anterior axial line at the level of umbilicus. Abdominal muscle was visualized and the probe was advanced toward the posterior after the visualization of dual muscle. The probe was positioned by identifying the intersection with the transverse fascia on the anterior side of the muscle. The lateral quadratus lumbar muscle was performed using an in-plane approach with the needle position lateral to the ultrasound transducer with an anterior to the posterior trajectory. Local anesthesia deposited at the lateral border of quadratus muscle at the needle penetration of the transverse abdominis epineuralosis by using the 20 gauge needle and 80 mm with a prepared solution of 0.3 ml per kg or 0.2% max 20 ml bilateral. The surgery was started. Intraoperatively injection diclofenac 75 mg was given in all the patients before the peritoneum. The hemodynamic parameter, that is heart rate, systolic blood pressure, diastolic blood pressure, and mean blood pressure, and SpO2 were recorded before the induction. After the intubation, the pre-block at insufflation, the 5 minute, 10 minute, 15 minute, 30 minute, 45 up to the 120 minutes after the insufflation and extubation in both the groups. If the heart rate or mean blood pressure or more than 20% of the baseline, the injection propofol 20 mg bolus was given. The number of patients requiring the propofol was recorded. If the still heart rate and mean blood pressure are more than 20%, then injection metoprolol bolus was given. The number of patients requiring metoprolol is recorded. The hypotension BP less than 95 50 mm was treated with methamphetamine 3 mg bolus. Intracranial pressure was kept below the 12 to 14 mm. Tail gas was stopped at 60. The glycoparin and shimmin was given with ondansetron. The post-operative, the patient was monitored for in pain for the post-operative NRS score and 30, 1 to 4 and 8 LR post-operative. Injection tramadol was given if the NRS is 4 or more than 4. Any complication like nausea, vomiting, local anesthesia is also with the bowel injection. Hypotension, bradycardia is detected. Total dose requirement of tramadol was noted, and rescue anesthesia injection diclofenac was given if the pain is same level given after the tramadol. The result, there is no difference between the two regard to the heart rate with comparison to the heart rate. In the mean blood pressure, there is no significant difference comparing the two groups. So the comparison of baseline mean blood pressure with the other time. In the group A, subcostal tab block at the 15 minutes, 13 minutes, 45 minutes post insufflation, the patient who received the subcostal tab block demonstrates statistically significant decrease in the mean blood pressure compared with the baseline. In case of group B, the lateral quadratus lumbar block, the notable decrease in blood pressure was observed post block up to the 1.5 minutes post insufflation, which was statistically significant compared with the baseline. In the pain score, comparing the pain score, the group B report their lower score than the group A, particularly in the first 4 hours. In the tramadol consumption, group B reported the lower tramadol consumption compared to the group A, that is tablet. The rescue analysis also noted that in total 22% required the rescue analysis and 90 patients belong to the group A, that is subpostal tablet, and only 3 patients lateral quadratus lumbar block require the rescue analysis. In the lateral quadratus lumbar group, a significant reduction in propofol and tramadol consumption compared to the subpostal tablet group. There is no significant difference in the mean duration of the surgery in the two blocks. The group B had a no-show meeting 30 cases, that is 75% of the total, and group B has a 12 cases, that is 30% of the total. No other side effects were observed in either group. Discussion: the laparoscopic cholecystectomy is considered with associated with significant hemodynamic change, intraoperative and visceral pain postoperative. The USG guided subpostal tab block, lateral quadratus lumborum block was considered safe for providing the hemodynamic stability. Intraoperatively, the subpostal tab block controls the hemodynamic variability to some extent from 15 to 45 minutes, while the QL block provides the hemodynamic variability up to the 105 minutes of insufflation. The hemodynamic stability in the lateral quadratus lumbar is also reflected by significant reduction in intraoperative propofol metoprolol consumption compared to the subpostal tab block group. The lateral quadratus lumborum block provides the superior postoperative analgesia, reduce the need of rescue analgesia, and decrease the opioid consumption when compared to the subpostal tab block in laparoscopic cholecystectomy. The transverse fascia investing the quadratus lumborum muscle is continued with the endothoracic fascia in the thorax, and it suggests that this is the pathway for cranial extension of local anesthetic spread to the thoracic paravertebral at the level of T10 and T11 level, and as high as T4 to T5 in some cases. This is at present the primary mechanism of action proposed for the QL block, but the further anatomical and imaging studies are needed to confirm whether the different QL block approach result in the similar pattern of spread. The conclusion: we concluded that the lateral quadratus lumborum block provides the superior postoperative analgesia, reduce the need of rescue analgesia, and decrease the opioid consumption where compared to the subpostal tab block in laparoscopic cholecystectomy. Intraoperative, both the block considered safe for providing the neck stability. The lateral quadratus lumborum block has better hemodynamic stability compared to the subpostal tab block. Thank you. These are my references. Thank you.
Okay, very good. Now, what type of pain do you get in laparoscopic cholecystectomy? Is it somatic or visceral or both?
Sir, both, sir, somatic and visceral.
Okay. Your title is this techniques you are adopting comparing for post-operative pain relief.
Yes,
Isn't
sir.
it?
Yes.
Then why you did not apply these techniques after the surgery? Why do you want to give it as a preventive measure, prophylactically, even before surgery?
Yeah, we can give, sir.
So now you are comparing the intraoperative as well as post-operative pain relief.
Post-operative hemodynamic. That's why we are given the after the induction we are given.
If you are doing it before the surgery started, you are also doing it as a preventive or a prophylactic measure, correct?
Yes, sir.
Now, tab block, does it produce visceral pain relief?
Visceral pain relief, sir, actually is providing the somatic more than visceral.
Practically nil. The tab block does not, you cannot perform a cesarean with the tab block. You can give only superficial
Yes, sir,
somatic pain relief, isn't it? Tab block was initially initiated to give post-op pain relief for cesarean sections. Okay?
Cesarean section.
And
yes.
Did you notice that you are doing it after induction of anesthesia? Both the techniques are performed only after induction of anesthesia, correct?
Yes, sir. Both the techniques are performed after the induction of anesthesia.
So turning an anesthetized patient right and left for quadratus lumborum block, is it cumbersome or is it easy?
No, sir. It is a compulsory troubleshooting. It's created.
So that point,
it's required the
manpower. So that is not a favorable point for that. If it is being administered in the supine position, then it is much more easier to do that rather than turning the patient with an endotracheal tube in situ or an LMA in situ and trying to shift the patient from supine to lateral on both sides. That's not in favor of the quadratus lumborum block, even though it can produce both visceral and somatic pain relief. You agree or not?
Yeah, I agree, sir.
You agree. Okay. So you used a maximum of 20 ml. So does that mean that it was equally given on both sides, 10 ml, 10 ml, or the volume was divided equal in both sides, or because both you have applied bilateral blocks in all the cases?
Pilot? No, sir. We have given the on each side. That 0.23 by 0.3 ml.
No. What I am asking is, after calculating the total volume according to body weight basis, did you give the equal volume
Then
on both sides?
yes, sir. Both the in equal volume on the both side.
Equal volume on both sides. Okay.
Equal.
So what was the purpose of? So you were completely avoided any opioids like fentanyl or morphine, or no opioids were administered throughout the intraoperative and postoperative period.
Intraoperative, we are giving the as per the institute protocol the 13 ml.
Fortwin you are given, but then why did
But
you
post-operative, we
require?
are not given it.
No. Intraoperatively, you gave diclofenac before the insufflation of carbon dioxide to create
Yes, sir.
pneumoperitoneum.
Yes, sir.
But in
Yes,
spite
sir.
of that, if there is a increase in parameters like tachycardia, hypertension, you started controlling it with beta blockers
Beta
like
blocker,
metoprolol and.
Yes, sir. Propofol.
Is that the correct way to do that? Blunting the responses with beta blocker, does it provide pain relief to the patient? It has been because the block has not been sufficiently powerful enough to block this visceral pain created by insufflation and manipulation of the organs. Controlling that with beta blocker and nitrates, is it the way to manage the pain?
No, sir.
Okay. Anyway, congratulations for thinking in a different line and
Thank you, sir.
performing a very difficult block. Of course, the quadratus lumborum block is not that easy like a tab block, and comparing the two techniques are worth a study. Good.
Maybe we should have changed the topic, sir, instead of saying just post-op analysis here, because you were doing it intra-op.
Yeah.
Yes.
The title should have been little altered.
Yeah.
Because you are saying it is purely for post-op pain relief. Administering it immediately before starting the surgery involves
Preemptive, becomes
the
preemptive
pain.
analysis.
Yes.
Preemptive.
Okay, sir. Okay, sir.
Okay.
Thank you. Thank you.
Right. Congratulations, Mohit. Good presentation. Your flow was very nice, and you had no hesitation in presentation. That was a beautiful way of presenting, and you were quite confident, and I appreciate the way you presented it. Thank you.
Thank you, sir.
Thank you, sir. Thank you, madam. Thank you, Dr. Mohit. Shall we move on to the next candidate, sir?
Yes, please.
Yeah. Next, I invite Dr. Gopika. Over to Dr. Gopika, please.
Yes, sir. Yes, sir.
You can share your slide.
Yes, sir. Entrance.
Do you need any assistance in sharing?
Yes, I think she is not able to open the screen.
Sir, I'm not able to share the screen, sir.
Okay,
Hello.
don't worry. You can send it to me in WhatsApp, or you can
Yes,
share
sir.
it in WhatsApp in the group. I will share it for you.
Yes, sir. Sir, I have shared it in the group, sir.
Yeah, I'm sharing it for you. Yeah. Is it visible?
Yeah, now
Yes,
it's
sir.
full screen.
Yes, sir. I'll
Sir,
make it
it's
full
just-
screen.
Yes.
Yeah.
You can start. You start.
Yes. Yes, sir. Thank you, everyone. Good afternoon, everyone. My topic for presentation is a randomized double-blind interventional study to compare the hypotensive properties of dexmedetomidine versus clonidine in adult patients undergoing functional endoscopic sinus surgery. My co-authors are Dr. Zinesh Kumar Sahu, sir, and Dr. Alpa Soda. It was conducted in the Institute Jagdiram Railway Hospital. Sir, how do I move the slides, sir?
Kamashi, I think you have to move the slide also for her. Yeah. Slide is moving now. Go ahead.
Functional endoscopic. Yes. Thank you, sir. Functional endoscopic sinus surgery is a common successful surgical procedure for patients with medically refractory chronic rhinosinusitis. Significant bleeding in the surgical field is a crucial determinant of potential success or failure of FES. In the presence of significant bleeding, identifying anatomical landmarks become challenging. Controlled hypotension involves a deliberate reduction of arterial blood pressures to minimize the surgical blood loss and improve surgical visibility. Various pharmacological agents are used to achieve effective blood pressure reduction. So next slide.
Move the slide.
During hypertensive anesthesia, the patient's baseline mean arterial pressure is reduced by 30% or maintained at 65 to 70 millimeters of mercury. Clonidine is a selective partial alpha-2 agonist that reduces the output of sympathetic nervous system from the central nervous system. This decrease in sympathetic nervous system activity leads to peripheral vasodilatation and reduction in systemic blood pressure, heart rate, and cardiac output. Dexmedetomidine is another highly selective, specific, and potent alpha-2 agonist agent, which is more highly specific, and it has sedative, analgesic, and anesthesia sparing effect. The study is designed to evaluate and compare the efficacy of dexmedetomidine and clonidine for producing controlled hypotension during FES. The aim of the study is to evaluate and compare the efficacy of dexmedetomidine and clonidine for producing controlled hypotension during FES. The primary objectives were to compare heart rate and mean arterial pressure from the baseline at different time intervals within each group and between groups. Secondary objectives are to compare the intraoperative quality of surgical field and blood loss during surgery between the groups, and also comparison of various postoperative parameters such as visual analog scale, sedation score, emergence time, time to first rescue analgesia, and proportion of cases with side effects. And these are my review of literatures. Many studies were conducted comparing dexmedetomidine and clonidine, but the doses also varied. The doses of which were compared in each studies was different. So next slide. Methods. Study area. The study was conducted in Department of Anesthesiology in Jagjeevanram Hospital, Mumbai Central, and it is a hospital-based randomized double-blind interventional study. According to the study conducted by the parent article Ushabafna et al., the sample size was calculated using this equation was very low. So as per the characteristics of normal distribution, a sample size of at least 30 per group was required to strengthen the thesis, and 60 of sample size was totally taken with 30 in each group. Sir, next slide, please. And study population. The study was conducted in ENT patient in FES. ENT patients undergoing FES procedure. This included patients of either sex and ASA grade of 1 and 2, and patients aged 18 to 60 years, weighing 45 to 90 kg. Those who were excluded from this criteria were the patients not willing to give consent for the surgery, or having history of coronary artery disease or heart blocks, or patient having history of autonomic neuropathy, renal dysfunction, hepatic dysfunction, and cerebral insufficiency. Pregnant and lactating mothers, alcoholic patients, and patients with bleeding diathesis, and patient positive for bilateral ethmoidal polyp, pediatric age group, and patient having allergy to study drugs were excluded from the study. And after obtaining permission from Institutional Ethics and Scientific Committee, and written informed consent was taken, and the patients were randomized into two groups using a randomization technique from the site randomization.com, and double blinding was done in such a manner that anesthesiologist who gave the anesthesia was different from the anesthesiologist who recorded the study variable. And a routine pre-anesthetic checkup was done a day before surgery. The 60 patients were randomly divided into two groups of 30 each. Group A received dexmedetomidine 1 mg per kg as loading dose over 10 minutes, and followed by 1 mg per kg per hour maintenance. Group B received clonidine loading dose of 2 mg per kg over 10 minutes, followed by 1 mg per kg per hour infusion. And the patient's fasting status and informed consent were confirmed. So next slide, please. Loading dose of study drug was given 10 minutes before induction of general anesthesia as per institutional protocol, and the maintenance infusion was started soon after the induction of anesthesia, and it was continued intraoperatively until 5 minutes before the completion of surgery, or it was stopped on the occurrence of hypotension below our target, whichever was earlier. And intraoperative hemodynamic parameters such as heart rate, systolic blood pressure, diastolic blood pressure, and mean arterial pressures were recorded at baseline, after the loading dose, after induction, 1 minute after intubation, 5 minutes after intubation, and thereafter every 10 minutes until shifting the patient to the recovery area. Surgical side was observed for severity of bleeding and the need for frequent suctioning by using average category scale proposed by Fromme Bossard. And blood loss estimation was done by measuring suction canister volume minus irrigation fluid used in surgery. And extubation was done in the patients who were responding to verbal comments. Emergence time was also calculated. Emergence time is defined as time interval between discontinuation of all the anesthetics to the response of eye opening to the verbal commands. And postoperative hemodynamic parameters were recorded 1 minute after extubation, 5 minutes after extubation, 30 minutes after extubation, 2 hours, and 4 hours after extubation. The sedation was assessed by Ramsay sedation score at 30 minutes, 2 hours, and 4 hours. And postoperative pain was assessed by VAS score every hour until the patient reached a VAS score of 3. Time to first rescue analgesia was noted, and patients were allowed to receive intravenous diclofenac 75 mg as rescue analgesia. Postoperative complications such as nausea, vomiting, shivering, dryness of mouth, hypotension, and bradycardia were recorded. And hypotension was defined as MAP less than 65 mg and was treated by stopping hypotensive agent and giving fluid bolus and injection mefentramin 6 mg bolus as per needed. Bradycardia was defined as heart rate less than 50 per minute and was treated with intravenous atropine 0.6 mg when not resolved by stopping the study drug infusion. And statistical analysis were compared using IBPM SPPSS version 22 software, and the test used were Pearson chi-square test, and comparison of proportion was carried out using Z-test for 2 sample proportion, and a p-value of less than 0.05 was considered statistically significant. The result obtained where both groups showed a significant decrease in mean arterial blood pressure value after the loading dose and after intubation. And whereas dexmedetomidine comparatively showed a more significant decrease in heart rate as well as mean arterial pressure throughout the surgery. And so next slide, please. Sedations. So previous slide, please. So previous slide. Thank you. Mean sedation score was significantly higher in Dexmed group, and the pain score, which was compared using VAS score, was significantly lower in Dexmed group. And also the mean time to first rescue analgesia was significantly prolonged in the dexmedetomidine group, with the dexmedetomidine group receiving analgesia at 137 minutes after extubation. A comparison of the blood loss and the surgical site bleeding was comparable in two groups, whereas the emergence time was significantly prolonged in dexmedetomidine group with an average of 14 minutes from the cutoff of all the anesthetics. And postoperative complication, the dexmedetomidine group showed a significant postoperative complications of bradycardia and dryness of mouth, whereas other complications were insignificant both. So our findings indicate that both dexmedetomidine and clonidine are effective in achieving controlled hypotension during phase. Both drugs are equally effective in achieving better surgical site visibility and minimizing blood loss. Dexmedetomidine demonstrated superior efficacy in several key areas. It was significantly better at achieving the target map value as compared to clonidine. Dexmedetomidine provided better postoperative sedation and analgesia, reducing the need for additional postoperative analgesics. Despite these advantages, it is essential to take consideration to potential side effects associated with dexmedetomidine, such as prolonged emergence time, postoperative bradycardia, and dryness of mouth, which were more prevalent compared to the clonidine group. And close monitoring and appropriate management strategies are necessary to mitigate these risks. Clonidine was equally effective in achieving a better surgical field compared to dexmedetomidine, with fewer postoperative complications like bradycardia and dryness of mouth and shorter emergence time. In conclusion, both dexmedetomidine and clonidine are equally effective in achieving a better surgical field in phase. With dexmedetomidine is significantly better at achieving controlled hypotension and providing better postoperative sedation and analgesia, whereas clonidine has advantage of fewer side effects compared to dexmedetomidine. And we recommend that dexmedetomidine and clonidine both can be preferred for achieving controlled hypotension for surgeries due to their comparable surgical site quality. Dexmed achieves more significant controlled hypotension and has advantage of better postoperative sedation and analgesia. Clonidine is more cost-effective and has fewer side effects than dexmedetomidine, significantly shorter emergence time also, and lesser incidence of postoperative bradycardia and dry mouth. Also, we recommend stopping dexmedetomidine 15 minutes before the end of surgery, as the emergence time was significantly prolonged in these cases. And conclude that the study was aimed to compare the hypotensive properties of dexmedetomidine and clonidine, and both dexmed and clonidine are equally effective in achieving a better surgical field in phase. Dexmedetomidine is significantly better at achieving controlled hypotension and providing better postoperative sedation and analgesia, and clonidine has an advantage of fewer side effects compared to dexmedetomidine. And these are the references I have used. Thank you.
Very good, Popika. That was a very nicely presented and very fluently spoken presentation.
Thank you,
what was the technique used by the ENT surgeons to reduce bleeding and improve visibility before the advent of clonidine and dexmedetomidine?
So they had used Trendelenburg position, reverse Trendelenburg position were used to decrease the venous pooling in the head region, and also oral clonidine they used to give before preoperatively. Tablet oral clonidine and
during our PT days and our earlier practicing time, when clonidine and dexmedetomidine were not available as parenteral preparations, are you aware of the history how we used to bring down the blood pressure if the surgeon requested for hypotensive anesthesia? Are there any vasodilators which can be used with a short action?
Many vasodilators like nitroglycerin and sodium nitroprusside were used.
Sodium nitroprusside, esmolol, all these drugs were the drugs of choice before the advent of dexmedetomidine and clonidine. Did you allow the surgeon to infiltrate with any local anesthetic and adrenaline in these cases?
No, sir. No, sir. The cases were not infiltrated.
They prefer to do that usually for test surgery, in addition to the hypotensive anesthesia that they request from anesthetic from the anesthetist. They always prefer to infiltrate with local anesthetic containing adrenaline to minimize the bleeding. Was there?
In these cases,
you didn't.
We had
to talk to your surgeon and ask them not to use that.
Yes, sir. We had talked to the surgeon and asked him.
So you depended mainly on clonidine and dexmedetomidine for reduced BP.
Yes. Yes, sir.
So how did you monitor the BP, non-invasively or invasively?
We monitored non-invasively only, sir.
When you want to check the mean arterial pressure, were you able to do it by non-invasive method?
Yes, sir. Mean arterial pressure was calculated directly from the non-invasive blood pressure measurements.
So that was only a calculated measure, not on an. So the ideal teaching is to have an intra-arterial line if you want to do a study to see whether the BP is really coming down to the desired level or not, and that is a more safer technique than depending on non-invasive technique, isn't it?
Okay, sir.
Did you
And
continue
why
the
did you choose
infusion in the
atropine to control treat the bradycardia? Why not glycopyrrolate?
We used atropine because it is fast acting and for more rapid action we have preferred atropine.
You said already this drug produces a lot of dryness of the mouth. In that such cases with atropine, will it not cause more dryness in the postoperative period?
Sir, but for a sudden action only we have preferred atropine.
So, but the correct answer is it responds better to atropine rather than glycopyrrolate. The bradycardia produced by clonidine and dexmedetomidine, it responds better only to atropine, not to glycopyrrolate that much. Okay, so that is the
Yes,
reason why people prefer to use atropine only.
Did you continue it in the post-operative period? Did you continue the infusion in the
no,
post-op
ma'am. We stopped the infusion 5 minutes before the end of surgery.
Both of them, both dexmed and clonidine.
Yes, ma'am. Both dexmed and clonidine.
Yeah, in that case, post-operatively, the bleeding, because they're not using Xylocan with adrenaline, any of them have not used. Was that a rebound hypertension? Rebound hypertension and bleed.
Known for rebound hypertension. That is a point Madam is asking. Did you notice any rebound hypertension and bleeding in the post-op phase?
Yes, sir. In few cases, we have noticed rebound hypertension, but it was not part of the study. But we had we had noticed rebound hypertension.
Okay. And your induction was standardized in all patients?
Yes, sir. We had an institutional
bonus dose of clonidine and dexmedetomidine, but you never mentioned what was your technique of induction of anesthesia, control of airway. What was that standardization? How was it standardized?
Yes, for all patients, we had used propofol. We had used 2 mg per kg, and Fordrin was given as an analgesic at that just before induction, and also midazolam and glycopyrrolate were given.
All these things were standardized according to body weight and given. Okay. So propofol itself will cause some amount of hypotension. So
yes,
did you give your clonidine and dexmedetomidine before propofol or after propofol?
Yes, sir. Loading dose was given before the induction, sir. For the pre-medication.
So did you experience any acute hypotension when you give propofol after loading dose of clonidine or dexmedetomidine?
No, sir. Right after induction, then when we proceeded to intubation, so it was almost blunted, like hypotensive was not there.
Okay,
so
good.
You said something about the anesthesia sparing effect of dexmed. What is that?
The requirement for anesthesia is less when we are using dexmedetomidine intraoperative infusion. Like the MAC value is needed is much less. We had also compared to the when we are while we are not using dexmed or clonidine infusion.
Did you say at any point of time that dexmed increases the mean arterial pressure, intraoperative mean arterial pressure? Or did I hear it wrong?
No, ma'am. It decreases the mean arterial pressure.
Sir, somewhere in between?
No, ma'am.
Okay.
It in rebound hypertension I had mentioned.
All right. Okay.
What is the mode of action of dexmedetomidine and clonidine? What are the phases? Do they immediately produce hypotension and bradycardia, or do they cause hypertension followed by hypotension and bradycardia?
They have some alpha-1 action, so they initially produce some amount of hypertension and gradually only hypertension.
It's a biphasic action. Initial short period of hypertension followed by hypertension and bradycardia. Okay. So during that time, your answer could be that also the propofol controls that hypertensive initial phase. So that is why you won't get much of a hypotension also because of propofol induction. Okay. Right. Good.
Thank
Thank
you.
you,
Thank
sir.
you.
Thank you, madam. Thank you, Dr. Gopika. Shall we
Thank-
move on to the next
thank you.
candidate, sir?
Yeah.
Yeah, next I invite Dr. Dhaval Patel. Dr. Dhaval, you can switch on your mic and share your presentation.
Unmute yourself.
Yes.
Your time starts now.
Yeah, I see. Yeah, it's visible. My poster is visible.
Visible. Perfect.
Okay. Thank you. Uh, uh, Good evening, everyone. My topic for poster presentation is comparison of hernia block versus standard subarachnoid block and open label randomized comparative study. We have conducted the study to for efficacy of ultrasound guided ilioinguinal, iliohypogastric, and genitofemoral nerve block. Comparing with subarachnoid block with patient undergoing for elective unilateral uncomplicated open inguinal hernia repair surgery. We have studied for 40 patients, age group between 18 to 80 years, with ASA group ASA 1 to 3 at Jagjivanram Railway Hospital. Patients were randomized in Group A and Group B. Group A was given subarachnoid block with 3.5 ml of 0.5% bupivacaine, and Group B was given ultrasound guided ilioinguinal, iliohypogastric with genital branch of genitofemoral nerve block. Both groups were studied for demographic characteristics like intraoperative anesthetic efficacy, success rate, duration of analgesia, hemodynamic changes, complication, time to ambulation, pain score, and patient and surgeon satisfaction. So, in ilioinguinal iliohypogastric block, the heart rate changes after intraoperatively. There is no significant changes in heart rate, and after subarachnoid block, general spinal anesthesia, there is 10 beats to 15 beats of decrease in heart rate after spinal anesthesia. There is a significant drop in blood pressure after spinal anesthesia, while there is no significant difference in ilioinguinal iliohypogastric block after there is no significant decrease in blood pressure, and there is time taken to perform block was 41 minutes in while there is shorter duration of time taken for spinal anesthesia. Onset of anesthesia is also faster in spinal anesthesia, while in block there is onset of anesthesia time was taken was 30 minutes, while duration of analgesia was longer period of time for 2 to 11 hours intraoperatively and postoperatively, and postoperative failure rate of block was 20%, while there is no failure in spinal anesthesia in our study. And time taken for ambulation was very less in ilioinguinal iliohypogastric block, while time taken was to ambulate was longer in subarachnoid block. Both surgeons and patient were satisfied significantly with subarachnoid block, with the satisfaction was graded as excellent by surgeon and very satisfied by patient. And with the block, surgeon satisfaction was moderate and satisfied from the patient side. So we have concluded that ultrasound guided hernia block may be considered as an effective alternative to subarachnoid block for unilateral hernia repair in terms of hemodynamic stability, post-operative analgesia, and lesser complication and early embolization. And my reference was taken for FACRI DM and Bang Vyas and Korean J anesthesiologist.
Okay, good.
Thank you. That was my poster presentation.
Okay, excellent. Now, did you make any particular criteria for selecting the patients for hernia block, like patient not being very obese or a patient having a huge hernia with a bowel or the momentum coming out in a huge sac? Did you rule out or exclude such patients, or you randomly selected all patients to perform the hernia block?
No, sir. We have excluded obese patient with and complicated hernia and with patient having significant cardiac comorbidities and patient having psychiatric illness who are not able to cooperate in study.
Okay.
We have excluded them.
Okay.
And we have excluded bilateral hernia also.
Bilateral. Bilateral hernia, when you are going to perform only one side, doesn't matter whether you do it. Okay, if both sides are not operated simultaneously, you can perform unilateral block in one patient with the other side hernia being planned for operation later on also. But now my question is, having excluded this sort of difficult cases, still you had 20% failure. What was the reason for that?
Sir, when surgeon was manipulating with SEC, that time there is
patient complaint of discomfort at the time.
Discomfort, yes, sir.
Okay. So normally in a hernia block, you must have a discussion with the surgeon and ask them to infiltrate around the sac before they pull the sac. That is the thing that we used to do as when we practice hernia block in those days with the surgeons. We used to tell them that they have to infiltrate the peritoneal sac around the internal ring level, so that sac pulling will not cause any discomfort to the patient. That is part of the hernia block, because you can't go and infiltrate at the time of intraoperative period. You can only give the block to the superficial ilioinguinal and iliohypogastric nerve and the genital branches genitophobic nerve, and then you have to keep away, and the surgeon only has to manipulate that step of infiltrating around the neck of the sac. And that
did you tell them to do that? Did you tell them to do that? You've not mentioned it anywhere.
Not actually.
Okay. So this is of course a very, very good technique for patients who are otherwise unfit for even subarachnoid block. Especially we used to do that in those days with marasmic patients who were very lean and who are waiting for surgery. Those days we used to have patients with florid tuberculous infection in the lung, and because of coughing they used to get hernia, and they were never fit for any type of anesthesia except hernia block. Okay, so it is I agree that it's a very useful technique in selective patients, as you rightly mentioned.
Yes, sir.
But otherwise, with the availability of a subarachnoid block and the convenience of good relaxation of all the muscles and the structures for the surgeon to do a good repair, definitely subarachnoid will score over hernia block. But as a technique which has to be learned by the postgraduates and practicing anesthesiologists, I appreciate you for presenting this paper, which many people may not be aware of. A hernia block, many students may not be aware of, because it is not practiced frequently like yesteryears when we were postgraduates and practicing anesthesiologists. Because of necessity, we used to do this as a part of our routine practice. So I appreciate you for bringing out this forgotten technique back into fore. And you did a good presentation, Dhaval. Congratulations. Thank you.
And I think he should also say, I mean, maybe insist on saying that it's a daycare procedure. For a daycare procedure, it will be absolutely.
For a daycare procedure, this will be a very good technique, because all the waiting for residual motor blockade to recover, delay in discharge, all this can be avoided for a hernia block. That's also a good, very, very valid point, Madam has raised now. Okay?
Yes.
Thank you.
Thank you, sir. Thank you, ma'am.
Thank you, sir. Thank you, madam. And thank you, Dr. Dhaval. Can we move on to the next candidate, sir?
Yeah, please.
Yeah, Dr. Gnanavel Selvaraj is our next candidate. Over to Dr. Gnanavel.
Yes, sir.
Please share your slide, Dr. Gnanavel.
Okay, sir. Sir, I am not able to share my PPT, sir. Shall I, sir? Hello, sir. Hello? Hello, sir.
You WhatsApp your slides to Dr. Kamakchellam. He will help you to
Yes, sir.
open the screen.
Sir, I share it in the group, sir.
Okay, is it the one? I'll share it for you. Wait a minute.
Okay, sir. Thank you, sir.
Dr. Dhaval has to stop sharing.
Dr. Dhaval, you close your screen, doctor.
Dr. Dhaval? You see the slide, sir?
Yeah, you have to make it full screen.
Yes, sir.
Yeah.
Nanavil, you
Okay.
can start. Your time starts now.
Okay, sir. Thanks, sir, ma'am. My poster topic was external oblique intercostal plane block for a patient posted for laparoscopic cholecystectomy. Upper abdominal incision is a cause of severe pain and can also lead to significant respiratory impairment in the immediate postoperative period. External oblique intercostal plane block is found to be simple, effective, and convenient method, particularly in the context of morbid obesity, and also it provides significant analgesia in the postoperative period. In my case report, a 40-year-old female admitted in the surgical ward for chronic cholecystitis planned for laparoscopic cholecystectomy. Patient was assessed under ASA 2 and shifted to operation theatre. Standard monitors were connected and preoperative vitals were stable. The case was taken under general anesthesia. Surgery was uneventful. Block was given before extubating the patient. Procedure: a linear probe was placed on the right side of the chest wall, just medial to the anterior axillary line over the 6th rib. A 16-gauge 2.5 needle was inserted from the supellar to caudal. After identifying the external oblique intercostal plane, the catheter was threaded beyond the needle tip and the catheter was secured. 0.25% of bupivacaine was 20 ml was given and the catheter left in place for 3 days for postoperative analgesia. The advantages of this block includes it can be performed in the supine position, significantly is more superficial, and catheter insertion is also distant to the operative site. These are my references, sir.
Okay. You gave it only unilaterally.
Yes, sir.
So will that cover all the port sites pain?
Yes, sir. It covers all the port site pain.
Was there any local infiltration done at the port site by the surgeon before you?
No, sir. No, sir. No local infiltration at the port site, sir.
Port site was not done. So
So
this
in the
was good
beginning,
enough to cover the post-op visceral pain
Yes, sir.
also?
It was good enough, sir. It was good enough to cover the post-op analgesia, sir. And also, I left the catheter in place for 3 days to cover the post-operative analgesia for 3 days, sir. It was excellent fluid and excellent analgesia for 3 days post-operatively, sir.
What was the rate of infusion? What drug did you use?
Not rate of infusion, sir. It's given as a bolus dose.
Intermittent bolus.
Intermittent bolus dose, sir. Yes, sir.
Okay. You don't use any elastomeric pump for continuous infusion? Or
No, sir. No, sir. No elastomeric pump.
So what was the
Use it.
frequency of bolus doses required?
Twice daily, sir.
Twice daily. Bupivacaine?
Bupivacaine 25%. Same 20 ml was given in morning and in the evening session.
So
twice
totally
daily.
40 ml per day.
Yes, sir.
So 3 days you didn't find any toxic reactions?
No, sir. No toxic reactions, sir.
What are the features of toxicity? Local anesthetic toxicity.
It includes cardiotoxicity, like bupivacaine includes cardiotoxicity like arrhythmias, hypertension, ventricular tachycardia, leukemia.
What is toxicity ratio?
Sir, for bupivacaine, sir.
What is toxicity ratio of a local anesthetic agent?
For any local anesthetic agent.
See, CC is to CS. Cardiovascular into CNS ratio. Cardiovascular versus CNS ratio. 7:1 for lignocaine, ma'am.
So was there any incidence of infection because the catheter was there and the intermittent boluses were given? Was there
No, sir.
any
No evidence of no evidence of infections, sir.
When did you ambulate the patient after surgery?
Sir, ambulated 24 hours after
24 hours? Laparoscopy after 24 hours only you ambulate in your hospital?
Yes, sir.
Nowadays it is done as a daycare. People are being discharged the same day. So within 2 hours they ambulate the patient.
Okay, sir.
That's the advantage of supposed to be the advantage of laparoscopic.
In the beginning of your presentation, Jnana Selvaraj, you said
yes, ma'am.
upper abdominal incision is painful. Now we are talking about laparoscopic surgery. So where is the question of incision at all? Right?
Ma'am, this can be performed for other surgeries like nephrectomy and plan. My case is for laparoscopic cholecystectomy, ma'am. It can be also performed for other abdominal surgeries like Whipple's procedure or in case of pancreatic tumor resection. So it can cover these surgeries also, ma'am. For effective, this block effective for those surgeries also. That's why I mentioned as the introduction part of upper abdominal incision.
You could have included a line diagram of the abdomen and the point of needle and the probe position, just like the other candidate presented. That could have given a better idea than incorporating only the ultrasound picture of the thing. Okay, so that could have made a better visualization for people watching this. Okay.
Okay,
and
sir.
plan to include that also. Reduce your authors and other spaces there and include a picture of the abdomen with the probe in position and then the point, the direction of the needle. If that could be depicted, that would have given a better idea than giving the ultrasound picture. And that's
okay.
Okay. Very good. Thank you.
Okay. Thank you, sir.
Thank you, sir. Thank you, madam. Thank you, Dr. Jnana Selvaraj.
Thank you, sir.
I think we had a wonderful session today. I hand over the session to Professor sir. Final concluding remarks, sir.
I congratulate. The only disappointing thing is only 4 candidates have come forward to present and prepare these their presentations. We expect more postgraduates to participate in this sort of. It's a good opportunity for them to, because nowadays a lot of importance is given to research and publications. Dr. Rakesh Garg, who is now the editor of IJA, he is trying to promote paper publications and research methodology. Every CME, every conference you attend now, you find a workshop on research methodology and paper presentation and all these things. So we should encourage more younger participants, younger postgraduates to come out with more presentations And today's presenters did a wonderful job. None of them had any hesitation in their presentation. Probably they have done a good rehearsal and homework, and their presentations were very lucid and very, very fluent without any hitches anywhere. And I congratulate all of them and wish them all good success. Thank you very much.
Yes, sir. Thank you, sir. Madam Vasanthi, madam.
Yeah, same. Actually, when I was thinking of what to ask, the same question sir will ask. So there's no point.
Wavelength of thinking is same.
It was just so good. I felt so nice about that. Right. They all did so well. Yeah.
Yeah.
Congratulations.
Congratulations to all, and also to their guides. Dr. Saku has done a wonderful work by giving good encouragement to his PGs. And they did a wonderful job by presenting nicely whatever topic they have taken. And they were also very bold in facing the questions. They were able to answer the questions also. That is very important in any presentation. So, very happy with their presentation as well as their response to the questions. I wish them all good success. Hope they all become the budding stars of our anesthesia faculty, and shine well in our specialty, to be proud, make the student teachers proud, like Professor Sahu who is teaching them. They should make your teachers proud. That's what we want. Okay, thank you very much. All the best.
Thank you, sir. Thank you, Dr. Dinesh Kumar Sahu.
Thank you, sir. Nagaswamy sir, we are indebted to you. You have taken for valuable time giving and to encouraging, assessing and guiding, sir. At the same time, we are also benefited by your guidance. Thank you very much, sir. Thank you, Vasanthi madam. Thank you very much. My camera is not getting on. I am sorry. From WebEx technique.
We feel disappointed not seeing
it is showing
face.
allow WebEx access to your camera. I have
Thank
to
you
go
very
to
much.
setting.
We'll come down to Chennai. We'll meet sometime.
Yes, sir. Yes, sir.
Thank you very much. Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Can we sign off today's session, sir?
Yeah, thank you. Thank you, Vasanthi, for the nice interaction.
Thank you, sir. Thank you, sir. Thank you, Kamachi.
Thank you,
nice,
madam.
Thank you.
Thank you.
Nice to be part of it.
Thank you, students. Yeah. Thank you. Bye.